Thank you so much. Good evening, everybody, and thank you for joining us for our webinar this evening. We are going to be discussing cataract surgery, and I am a professor and associate professor of ophthalmology, and my area is cataract, cornea, and refractive surgery. So in this evening's presentation, we are going to discuss a lot of the symptoms and what can lead to cataract surgery, and then talk about what options we have and outcomes, and then kind of close with a brief overview. So here are our objectives for this evening. We're going to hit what is a cataract, why does it happen, talk about segments of the population that are at risk for cataracts, including the older population, what kind of impacts we can have in our daily living with this, specifically with driving, special considerations with preoperative evaluation, what the process in cataract surgery is, and I will be sharing some surgical videos for you. So just in case if anybody's a little faint at heart of watching eye surgery, you may want to not watch for those few videos, but I do think it's important to kind of get a sense of what's involved with the surgery. And then we will talk about some of the postoperative care and potential risks and things that anybody potentially having cataract surgery should consider. So I think it's very important to discuss what the anatomy of the eye is and what we're talking about when we're saying cataract. So the cataract is actually forms in the lens, and the lens is within the eye. So we have the clear front part of the eye, that's the cornea. And when you're looking at someone's eye, a lot of times you're seeing the colored part, which is the iris, which is just posterior to that. And then just behind that is the actual lens. When we're born, this lens is crystal clear, very soft, and mobile. And as we get older and the eye matures, this lens is what actually turns into the cataract and can affect our vision. Behind the lens, we have the eye is filled with a jelly, or what we refer to as the vitreous, and then we have the retina. And that's basically what images are being focused on, and that via the optic nerve is then sent to the brain, and that's how we can kind of sense what we're seeing. So if we kind of imagine like an old school camera, the lens is kind of similar to the lens in a camera. It's basically allowing the images to be focused on the film or the retina of the eye and allowing us to see what it is that's around us. So a common complaint that comes into my clinic is I'm here to have my cataracts removed. So it's actually, yes, it's cataract, not Cadillac. So what is it? This is basically age-related natural changes to the human crystalline lens. And on average, this starts around the age of 40. Now, there can be conditions such as congenital cataracts or pediatric cataracts, or sometimes trauma that can lead to a cataract forming sooner. But for the most part, cataracts start around the age of 40 and continue to progress as we get older. And kind of as time goes on, that ability of the cataract to affect our vision is referred to as a dysfunctional lens index. So that's something we can kind of follow to see how much the vision is impacted by the cataract. And so kind of what we were talking about in the previous slide, with the lens becoming more hard and getting a more yellow color, this causes issues with focusing and also scattering of lights. And 90% of the time, this is due to maturing or getting older. But there are some risk factors that go in the formation of cataracts that can potentially cause these to form quicker or at a younger age. We do know that extensive exposure to UV light can cause cataracts to form quicker. Systemic conditions such as diabetes can also cause cataracts to form faster. We mentioned trauma, but any sort of like severe trauma to the eye can cause a cataract to either occur at a younger age, or if there is a cataract present, to kind of start maturing at a faster rate. And then various medications potentially will have side effects that can cause a cataract that would have ultimately progressed to start progressing a little bit quicker. One of the more common ones is steroids. So that could be various inhalers, or if, taking a steroid orally, or even injections. So many people kind of want to know how does a cataract affect their vision? So this is kind of a demonstration of what a cataract does. It basically lowers the contrast and the overall quality of the images that we are seeing. So you can kind of tell, yes, there's two children here, there's balls, but that they're holding in their hands, but there's the actual contrast, the colors, the crispness, that's what we're losing as a cataract progresses. Just kind of showing you here, when we are examining you in clinic, we're actually seeing some things. So here you can see these are pupils that have been dilated, but there's all different types of cataracts. So there's a posterior polar cataract that's more commonly a congenital cataract that forms on the back, but a lot of our focusing we're doing in that back center. So these types of cataracts can quickly progress and become more visually significant. More common of a cataract that I see when I do international work would be a mature or hypermature cataract. You can see here, you don't have to be an ophthalmologist to diagnose that this is going to be impacting the light and images going into the eye. And so just kind of demonstrating you how that cataract can look in different ways. So probably the next most important thing are what are the symptoms of cataracts? And so the most common symptom is blurring of vision. So this can be, with anything, such things as difficulty with reading, driving is a common complaint. And one of the earliest signs of cataracts is glare and progressively getting worse. So initially kind of showing up in dark environments, like for example, when you're driving, and then this can kind of progress to even during daylight, the glare can be symptomatic. We kind of hit on this, but also decreased contrast. So a lot of times I have a lot of patients who are artists and they pick up on this very quickly, but just overall decrease in quality of vision is what we mean there. And then the other thing is, as a cataract, when it first starts to progress, we'll have a change in the prescription, whether you wear glasses or contacts. So a little adjusting in that prescription can get the vision improved, but it basically is a moving target. So as that cataract continues to get worse, then the prescription not only changes, but the vision with the updated prescription, whether it's glasses or contacts, is not as good as it initially was. And that's kind of the process we see. And so when you're seeing your eye doctor, this is kind of part of the equation in determining when it's right to have cataract surgery. And so obviously this continues to progress and can affect vision at all times of the day. So this is very common. About a third of people over the age of 65 have some level of decreased vision. And so why we care about this is because vision is so important in our daily activities. And so it can affect what we're able to do safely or comfortably. One of the more important things that I guess, many don't kind of factor in there, that there is a psychological strength in being independent. And so when our vision is affected, that's one of the things that many people start to lose first. And that can not only affect our ability in our day-to-day, but also our overall mindset. The other thing is it can affect our mobility. So things like depth perception can have a dramatic effect on things such as falls and places at risk for fractures. And so obviously, if we can do something to avoid that, it's very important. And then, once again, if our vision is not great, we may not be able to drive to meet with our friends and family or be able to do things that we enjoy on a regular basis. So these are all kind of why we care about cataracts and why it's so important to consider cataract surgery when the cataract is affecting vision. The other thing here is there are many conditions that can affect vision. Cataracts are the third most common cause of vision loss. Now, there's three other conditions here that we're not covering tonight, one being macular degeneration, glaucoma, and diabetic retinopathy. The thing that sticks out with cataracts is the vision loss to cataracts can be restored with cataract surgery. Different with these other conditions, when there's progression and it's affecting the vision, unfortunately, right now, we don't have treatments that can bring back any vision that's lost. So that's why it's really important to continue to have eye exams and be screened for those. But that's the positive thing about cataracts, is that not only do everybody get cataracts, but the vision loss can be restored. So the other thing that's really important here is that driving is very dependent, and driving safely, I should say, is dependent on vision. And so we know that with poor vision, this can affect overall ability to drive safely. And there's been a correlation with increased car accidents when cataracts are affecting vision. Those over the age of 65, interestingly, are the fastest growing group of drivers that are out on the road. So once again, it's really important not only for independence, but being able to drive safely, and also for us as well. If there's other people driving out with cataracts, it places us at risk as well. And we all just know there's a lot involved with car accidents, so we want to avoid that. This is actually a real life photograph of a patient from a previous place that I worked at that drove themselves to their cataract surgery. So a lot of times we think that we're driving safely, but you don't know, you might press the gas and accidentally drive off the wrong floor in the parking lot. So once again, this stuff, it does affect vision, and it is important that we are monitoring and considering cataract surgery when the vision is affected. So why is driving so important? Because it's, especially in Southern California, it's one of the primary modes of transportation. It also helps distinguish us in terms of our independence. And so if we want to drive somewhere, we have that ability. And so, like previously mentioned, there is a correlation when we're not able to drive, that this can lead to depression and social isolation, mainly because we're losing that independence. And so once again, kind of balancing this, obviously, when you have a cataract early on, it doesn't mean that you have to have cataract surgery. But as that cataract progresses and the vision is not as good, and the glare is getting more symptomatic, that's when cataract surgery probably makes the most sense. So just here's a diagram. I just want to help illustrate what we're talking about. So on the left, these are two images. The top left, this is basically showing a little child by a vehicle in normal contrast situation. So when we decrease the contrast, like what we see with a cataract, at that point, it's really difficult to see that there's actually a child here. So if we're driving, it might be difficult to make this child out, and in terms of safety for that child or other things that might be in the room, it can definitely affect our quality of vision. And so one of the things that I mentioned is glare, specifically nighttime with driving. So when we're driving, and obviously nowadays with these newer vehicles that have these LED lights, it's much more pronounced. But anytime we're looking at an oncoming car, there's going to be some distortion around lights, but the glare and distortion created by a cataract, you can see here, it's actually affecting our overall field of vision and our ability to kind of see in this area. So this is very significant and can really affect our ability to safely drive. Once again, just trying to demonstrate the differences of what we're talking about with glare and also contrast that go along with cataracts. This is just a study we wanted to share that actually showed that having cataract surgery does reduce your risk for having basically unsafe driving or a car accident by half. So maybe one day the insurance companies will take on this and give you a discount if you've had your cataract surgery. And so the next topic that we were going to hit on this evening was what we kind of consider preoperatively when it comes to cataracts. So it is important that we are aware of your medical and surgical history, just because with cataract surgery, as we're going to talk about in a little bit, there is some anesthesia involved. So we need to make sure that your medical history, we're aware of all the medications you're taking and any potential high-risk situations, that you're optimized by your primary care doctor before we proceed with any sort of surgical procedure. So this may require cardiac clearance or further testing. And this is something that we work closely with your primary care doctor to just ensure you're cleared for the surgery. It is helpful for us if we can have, a history of visual acuity, so that being your overall vision, and then what your vision is with your current glasses and what's the best vision that we can get. So once again, it's really important that you have consistent follow-up with an eye doctor, for example, with us at the Gavin Herbert Eye Institute, so that way we can continue to have more data points and monitor how much the cataracts are affecting your vision. It's really important to also have a detailed examination of the eye. So there are conditions that can limit what types of lens technologies that we can consider that we'll talk about in a few slides. And also we need to make sure there's nothing else that needs to be taken care of before the cataract surgery. For example, if you have diabetes and you have evidence of diabetic retinopathy, we need to optimize that first before proceeding with cataract surgery. And so that's something we're not going to pick up unless we do a detailed eye exam. And then we are very blessed at the Gavin Herbert Eye Institute that we actually have access to the latest and greatest imaging technology, which allows us to better prepare and plan for the intraocular lens placement. And so this is something that we refer to as an intraocular lens. At the time of cataract surgery, when we remove the lens from the eye, we have to place a lens inside the eye to help for the focusing. And we're going to get into that in a little bit, talking more about what options are currently available and the differences in potential vision that comes along with those. But once again, it's very important that we have great data points and imaging. That way we can ensure that our lens power is correct. And then it's also obviously important to set expectations and help our patients understand what is involved with cataract surgery, including the post-op regimen and course as well. And then, of course, any medical procedure, we do need to have your permission and your consent. So that's a conversation that we'll go through. Just like any other medical procedure, cataract surgery is an elective procedure. The chance of having improvement in your vision is very high and very likely. We'll get into the data in a few slides as well. But like any other medical procedure, there are risks. Things like infection, inflammation can occur, and we'll hit those near the end of the presentation. So the vast majority of cataract surgery is done under topical anesthesia. So what this means is we have an anesthesia team in the room who's monitoring you and giving you sedation by an IV. So you're relaxed and sedated, but you are breathing on your own. So it's not high risk general anesthesia. And then additionally, you receive both topical anesthesia to numb the surface of the eye and then actual anesthesia inside the eye to completely numb it. So that way you're not able to feel the surgery itself, and it's relatively comfortable. The other benefit of this is that patients, later that day, the next day, they're back to normal, just given we don't have to proceed with general anesthesia. We do have the ability to perform general anesthesia for our patients that are healthy enough, but we tend to reserve this more for people, for example, for children who are unable to undergo this procedure just under IV sedation, or in cases, for example, with early dementia, where our patients may forget that they're in the operating room, and it's important that they stay lying down and not try to jump up during the procedure, and other potential conditions that we can consider. But for the vast majority, this is less than 1% that we consider general anesthesia. The surgery itself is very quick. Every cataract is different, but average takes about 6 to 15 minutes for the actual surgery. Now, it does take at least an hour to get our patients ready for the surgery. And then we usually keep our patients in the recovery area for at least an hour after the surgery. So the whole process, you're looking at like a 2.5 hour procedure, but the surgery itself actually is very quick. And with technology, we've really improved the overall technique, and also that includes the overall time it takes to perform the surgery. For the most part, our patients who are on blood thinners, whether that's aspirin or something like warfarin or Plavix, you don't need to come off your blood thinners. For cataract surgery, we're not near any blood vessels that would be at high risk for bleeding. Now, if it's cleared by your cardiologist or your primary care doctor to hold it for the surgery, that's great, but it doesn't mean that we can't proceed with the surgery if blood thinners cannot be stopped prior to surgery. So overall, the surgery itself is done through a micro incision. So it's about 2 millimeters. You can see here in the diagram. And through that small incision, we are using a pair of micro forceps to create a circular opening. The more circular, the better in terms of the visual outcomes. So that way we can access the cataract within the lens capsule. And then modern cataract surgery involves utilizing a ultrasound probe that both irrigates and aspirates and has some energy with ultrasound to break the cataract up into little microscopic pieces and remove it from within the eye. So you can see there's various techniques to do that, but for the most part, we do like to kind of break it up into different quadrants and then remove that from the eye itself. And then after the cataract's been removed, we switch to a more blunted tip that doesn't have ultrasound. And that's used to just remove the final layer of the cataract that's it's almost like an onion. It's just a lining of the capsular bag. Because our goal is we want to preserve that capsular bag that the lens is in, because that's what our intraocular lens implant will go into and become part of the eye. So once all the cataract's been removed, through that small incision, we actually are able to fold a lens almost like a taco and insert it through that micro incision. And then that lens goes into that capsular bag, centers, and you can see here where the cataract was. And so this kind of helps us with focusing and just allowing for better quality vision after the surgery. So here, just kind of giving you a side view of where the lens sits over time. Usually within about a week, this capsule has scarred down to the lens, and the lens has basically become part of the eye and stable. So here is a real-time one of my cataract surgery videos to kind of demonstrate. If you kind of get queasy with blood or with procedures, you may want to just take a break from the screen. But here you can see how small the incision is. And then because we want the eye here's the anesthesia. So this is just some anesthesia to numb the eye. And at this point, the eye is completely numb. And then after this, we insert a gel that kind of keeps the eye inflated, so that way we don't have to worry about the eye deflating during the procedure. And here's that main incision. So it's just about 2 millimeters. And then next, we're going to proceed with making that capsular opening. So a very fine forceps. And then once again, this is done by hand. We're going to talk about laser in just a moment, but basically trying as much as possible to keep this opening as circular as possible. And so just reminder, our patient is awake and very comfortable right now and doing fine. And so once we've got that circle, that basically completes that opening. Next, just using some fluid to make sure the lens is freed from inside the bag. It just puts less trauma on the eye itself. So you can see here the cataract is actually able to be moved within that bag. And then this is that ultrasound probe. So with this, I use a chopping technique where I basically chop the cataract into small quadrants or sometimes into 6 pieces. And then it's removed from inside the bag. This space that we're working in, I mean, this is something I do very often, probably like 20 to 30 of these a week. It's a very small space, but you can see here we're respecting the anterior and the posterior margins. And so this is a relatively safe procedure for the eye, just given that we're staying in that same plane. And so here we are with that last big chunk of the cataract. And then we're moving on basically to removing that onion layer. Here's one layer of that. And then I switch to the blunt handpiece next, and then remove the final layer. So you can see there's still that lining, and then the bag is intact. So this is kind of that more blunt handpiece. So it just has no ultrasound, but just suction. So just peeling off that inner lining. And then once this is complete, basically the cataract is gone, and all we have is a preserved bag that the cataract was in, and that's what we'll place the intraocular lens in. So just forwarding here, this is that lens. We folded it like a taco and inserted it into the capsular bag. And then basically it becomes part of the eye, and that's cataract surgery in a nutshell. So this was actually not edited to speed it up. We're looking at, minus the beginning and the end, it's about 3.5, 4 minutes. So not a long procedure. So the next thing is, what are the intraocular lens options, and what's covered by insurance, what's not covered by insurance. So cataract surgery itself is considered a medical procedure, and insurance does cover a standard monofocal intraocular lens, or IOL, for the procedure. And what that means is, when we say monofocal, is that there's one focal point with that lens without glasses. So if we set it for distance, things far away are going to be more clear, but then with that lens needing more reading glasses for up close fine print. We can do the opposite, where the lens is set for up close, so not needing reading glasses, but as things move further away, or things in the distance, that's where things will be blurry without glasses, and then patients will need glasses for distance work. There's also something called monovision, and this is something that some people they do in contact lenses. So it's important that this be something that you've tried before, but this is where the dominant eye is set for distance, and then the non-dominant eye is set for up close. So we can do that with the standard lens implant. And so for about 50% of people, their brains can adjust to this. And so that way they've got one eye doing their distance work and the other eye doing their up close. But with this lens, it doesn't allow for additional focus points, and it also doesn't treat astigmatism. Astigmatism is different, and it has to do with the shape of the cornea, and we'll kind of get in a little bit more in a few slides. And on the other hand, we have lifestyle lenses. So these are lenses that are not covered by insurance or an extra out-of-pocket cost, but the benefit is you get some extra focal points with these lenses. And not everyone's a candidate for these lenses. Any sort of other eye conditions can get in the way of being able to be a candidate for these. For example, having severe glaucoma or macular degeneration or severe diabetic retinopathy. But outside of those, they are great options for people who are trying to be less dependent on glasses for many of their daily activities. So there are multifocal lenses. These lenses, they're different than, for example, a multifocal contact lens or a progressive lens that's in glasses. They work a little different, but through optical principles, they can give you a few focal points. So they can give a focal point at distance, a focal point at the computer screen, and then potentially a little bit closer than the computer screen, to allow for the ability to kind of do those things independent from glasses. This lens does come in an ability to treat astigmatism as well. And there are extended depth of focus lenses. These lenses, a little bit different than the multifocal, because they give a good focal point at distance, and that focal point is extended to intermediate. So this lens is really good for someone who does a lot of distance and computer work. Obviously, the caveat is giving up on the up close. Anytime you're gaining more focal points, there is a little bit of an increased chance for decrease in contrast. Specifically, for example, a little bit of a clean halo around lights at night. So more common with the multifocal, although we're talking about 10 to 15% of patients experience that, versus extended depth of focus, less likely with that option, but obviously giving up the fine print up close. There are also, the latest technology when it comes to IOLs is light adjustable lenses. So these lenses, we place them in the eye, and then we have the ability after the surgery to adjust them depending on what our patients like. So with these, we can set both eyes for distance and kind of adjust one eye and bring it in to give a little bit more up close, and let our patients try it out. And then if they're happy and they like that, then we can lock it in. So with this, really, it's the best option for our patients, just given that they have full control and they can decide where they want their focal points to be. With this lens, it does behave like an extended depth of focus, where there is an actual range, but the difference being that our patients are able to kind of move and adjust that focal point after the surgery, and it doesn't involve an invasive procedure. We can do that in clinic. We kind of hit on astigmatism correcting lenses. So these we refer to as torics. This basically, with the cornea, it should be a normal spherical shape in all the meridians. But when somebody has astigmatism, that'll be in one meridian instead of being a sphere. It's a little bit more pointed like a football. And so that can affect our vision just because when we're looking at something, the edges may not look completely crisp and or maybe a little bit doubled. And that's astigmatism. And so that lens option is available, for example, for our patients that want really good distance and their astigmatism treated. They don't mind wearing reading glasses. That lens is available. And then it also is available in all the other lifestyle lens options. So this is a diagram or video kind of just showing that someone who doesn't require any prescriptions when they're younger, they can see distance, intermediate, and up close. And then as we have the normal maturing process of the eye, we start losing that up close, that intermediate, and then the overall quality of our vision decreases. And then here just kind of demonstrating what the vision can be with a multifocal, given those multiple focal points. So being able to see distance, far away, and up close, and also kind of demonstrating the difference in nighttime vision with a regular monofocal versus a multifocal. You can see here, you can see things far away, the dashboard up close, but there is that potential for a little bit of distortions around light. Not as bad as, for example, the cataract before the surgery that was really affecting the vision, but this is something that can happen with a multifocal lens. So just kind of showing you here the different types of lenses and how they look. This is the light adjustable lens. So basically we place that lens in the eye and then through UV light, we can adjust the shape of that lens and basically induce some prescription and correction. And then once our patients are happy, we can do another UV treatment to lock it in place. The newest model of this lens actually does have a active shield on it. So for the most part, no concern for being around UV lights before this lens is locked in place. But we do recommend in that post-op period until we've finalized the aim of the lens that our patients wear a UV protective lens just to kind of potentially prevent any sort of adjusting of the lens that we aren't intending to. But once it's locked into place, those UV glasses do not need to be utilized. You can see here in this diagram, this is actually a patient having an adjustment. So it's basically almost similar to our slit lamp exam, where we're able within a minute to minute and a half change the prescription and let our patients try that out. And then, if they're happy, lock it in. If not, consider another adjustment until our patients are happy. This is just kind of demonstrating there are different types of astigmatism, and what these pictures are topography, so almost like elevation maps of the cornea or the front part of the eye. You can see here on the left, we have a regular symmetric astigmatism. So this is something we can definitely correct with an astigmatism correcting intraocular lens. We have cases where it does look symmetric, but there's a little bit of difference between one side or the other. In this kind of a situation, we'll want to understand why. If it's due to something like dry eye, treat that, optimize it, and then reassess to see if we could correct it with an astigmatism correcting lens. There are cases of irregular astigmatism like keratoconus. In those situations, we tend not to correct with astigmatism correcting lenses just because it's totally not regular astigmatism. So the astigmatism correcting lens may not completely treat the astigmatism and improve the visual quality. So just kind of showing you what we're talking about when we're talking about astigmatism and a regular astigmatism. There is another lens that we actually do have available at the Gavin Herbert Eye Institute, and it is the IC8. This is a small aperture IOL. So similar if you've ever tried a pinhole pair of glasses, or when you come in, we check vision with pinhole. Basically, the technology here, this lens goes in the non-dominant eye, and basically this lens is within the pupil and the vision of the patient. They're seeing and focusing through the central optic. And so with this pinhole effect, they actually are able to have a range of distance to up close in their non-dominant eye. So basically, the best way to get monovision without losing any potential depth perception. So once again, we have all different types of technology available to mix and match for what our patients are looking for. Now, one of the greatest advancements for cataract surgery, like I previously mentioned, conventional cataract surgery is done with ultrasound, but the femtosecond laser has been able to be used to assist cataract surgery. And really why this is helpful for us is the cataract itself can be softened before we even started the procedure with the laser. We can also treat low levels of astigmatism with the laser. So someone who, for example, has astigmatism, but not enough for an astigmatism correcting lens, we can treat that with the laser. It also makes a capsulotomy or the opening to the cataract. Remember that kind of part of the procedure where we make that circular opening. But when we're doing it with the laser, it's perfectly centered and perfectly circular. And we can also use the laser to make our incisions, so there's no blades involved. There are different platforms, but here is a graphic I wanted to show you from a study. The top left, these were basically those capsulotomies or the openings to the cataract, a lens capsule made with a laser versus when it's made by hand. So, in real life, all these cases, they looked, pretty circular, but you can tell there's a difference, a notable difference between when we do it with the laser versus non-laser. So here, just kind of demonstrating how, when we make the capsulotomy, it's more precise. We can use the laser to actually soften the cataract, so it's pre-softened, so potentially lowering the amount of energy needed to remove the cataract. And then we can make these microscopic incisions to treat the astigmatism. And then also make our incisions with the laser as well, so they have 3D architecture, and we don't require a blade for those incisions. This is just one of the platforms. We have this available at the Gavin Herbert Eye Institute, but basically you can see here, not only can we use the laser to do the treatment, but we can do an additional measurement to just confirm overall treatment of the eye. So here it's just basically showing that with the OCT technology before the procedure, we can actually do high definition imaging of the eye, and that just makes our treatments much more precise. And then this basically just kind of demonstrating to you, the laser part is pretty quick. It takes about maybe 30-40 seconds to do the measurements, and then probably another 30-40 seconds to do the laser portion. So this is a real-time video just demonstrating you with the Catalyst platform of that treatment. So you can see here the eye is in place and has gentle suction, so the patient is comfortable. The laser has the eye where it needs it. It's made the opening here that's perfectly circular. You can see in our timing, we're about under 40 seconds left. So it's continuing to pre-soften the cataract. And then once that's done, it's going to do the astigmatism treatment, which would be here. It's kind of flashing back and forth to show you what it's working on, but it would be the yellow arc will come next for treating the astigmatism. So about 10 more seconds remaining to soften the cataract. And then this is that astigmatism incision being made very quickly. And then the last part would be the cataract incisions. So this way we don't have to do it with the blade. This, adds about 10 seconds. And that's the laser portion of the cataract surgery. So at this point, basically almost 50% of the surgery is already done before we've even started. So here, just demonstrating to you the difference here after someone's had the laser. You can see here the cataract has been softened and pre-cut into these little small wedges, and the surgery just is much quicker and less stress on the eye itself. So you can see here now these little pieces very cleanly are going to be removed. Obviously, the capsulotomy was already performed with the laser, but you can kind of see here there is a perfectly circular opening there. And so this just adds to the precision and lowers the time and potentially the risk associated with the surgery and the post-op healing. Otherwise, everything is pretty similar when we do it with or without the laser. So the next most important thing is what should we expect after the surgery? So our patients tend to be sent home with a clear shield on the eye. The eye is not patched. And so with that, basically, patients are able to see. It does take a full week for the vision to settle, but using the eyes is no problem. But every day the vision improves, and then by a week the healing is mainly done. Some surgeons do not place a shield on the eye. For me, I do, just because I know how easy it is to forget that you just had eye surgery and rub your eye pretty aggressively. We currently do have post-op drops. There is a movement to hopefully limit the amount of drops needed after surgery. But for the most part, our regimen is 4 weeks of drops, and we have 3 different eye drops. One is an antibiotic that is for 1 week, and then it can be stopped. And then we have 2 anti-inflammatory drops that we taper off over 4 weeks. So we start at 4 times a day, and every week we come down by 1 until our patients are off them. The other consideration is not to be performing any heavy lifting. So to us, that's more than 10 pounds for the first week, or really bending past the waist for prolonged periods. Anything that's going to increase the pressure in our chest, those kinds of activities should be avoided for 1 week after cataract surgery, and then after that, normal activity can be resumed. We do recommend for that first week as well to tape that clear shield over the eye at bedtime and avoid sleeping on the eye that had surgery for a week as well. Once again, just to avoid in the middle of the night waking up and accidentally rubbing or hitting the eye, just because that definitely is possible. In terms of post-op appointments, we tend to see most of our patients the day after surgery, just to confirm the healing process has started well and that our patients are using the correct drops. Eyes, for the most part, we tend to do them separately. So we usually start with the worst cataract first and do the second eye to follow. The second eye can be done as soon as 1 to 2 weeks after the first eye. But if a patient wants to extend that time, we definitely can extend it. But for the most part, we don't do them sooner than 1 week apart. We usually have a visit about 2 to 4 weeks after the surgery. And then usually by 3 months. And then after that, we're pretty much done with the post-op visits, and our patients can go back to their regular eye exam regimen. So let's talk about outcomes and complications. So I think the most important thing to focus on here is that cataract surgery is the most commonly done surgery in the United States. And outcomes are very high. We have a 97% success rate. So not many surgeries have that high of a success rate. Although complications are rare and don't happen often, it's always possible. Things like infection, you can see here, according to the literature, it's anywhere from 0.01 to 0.1%. And with this is something that if we pick it up early and start treatment, we can prevent any sort of bigger problems. Obviously, if it's not taken care of early on, it can lead to need for further surgery or stronger antibiotics. But once again, this is not something we see common, and this is one of the reasons why we have our patients use the antibiotic drops for 1 week after the surgery. Having an elevation in intraocular pressure is a common event that can happen after cataract surgery. The vast majority, the pressure normalizes and goes back to normal. In some instances, the pressure may not go down. And so in those cases, we have to start some eye drops to lower the pressure. And for the most part, that takes care of it. And so that's another potential risk. And then there are risks for retinal tear, retinal detachment. So the overall risk after cataract surgery, although it's low, it's real. You can see there's 0.01 to 0.02%. There are some conditions where the risk for retinal tear, retinal detachment may be a little bit higher. That would be for someone who already has had a retinal tear, retinal detachment, or someone who's very nearsighted. So in those cases, obviously, we will keep a closer watch on those patients, and also very important to know the signs and symptoms of a retinal tear, retinal detachment. For example, having lots of new floaters that come in the field of view that were not there, or having a curtain coming across a field of view, our patients being able to see on one side but not the other, or lots of new flashing lights like firecrackers going on in the eye. Those would be all conditions that we'd want our patients to come in to be evaluated as soon as possible. Another situation that happens 100% of the time after cataract surgery is what we call a posterior capsular pacification. And this is normal. This is basically the back of that capsular bag can start to stick to the back of the lens. And when that happens, it can create some slow haziness that can occur affecting the vision. The great news here is that with a laser procedure that we do in clinic, it takes just a little over a minute to do. We can take the vision back to what it was right after the cataract surgery. And this is usually something that our patients have to have done once in their life. Sometimes it could occur a few months after cataract surgery. Other times it happens 10 to 20 years after cataract surgery. But once again, nothing that would permanently affect vision. And it's a non-invasive procedure that we can do that's covered by insurance to clear that. So to close here before we hit the questions, cataract surgery is the most common done surgery in the United States. And for the most part, this is a great procedure to regain normal visual function and help with daily activities when the cataract is affecting our visual quality. Although risks are there, the overall risks are low, outcomes are very good. There's kind of been an old term that's been used sometimes to say your cataracts need to be ripe to be taken out. For the most part, with modern cataract surgery, when our patients are having symptoms and it's affecting their quality of life, that's when we need to proceed with the cataract surgery. We briefly went over the many intraocular lens options, but the great thing is with the technology and all the advancements, a lot of these lenses can be tailored for what it is that you are looking to get out of your day-to-day activities, whether wanting to be independent from glasses or being okay with wearing glasses after surgery. So that's all I have prepared. I think at this point, we've got quite a few questions, so we can go ahead and open up the questions and hit them.
Thank you, Dr. Behshad. Our first question is, why do cataracts give you glare?
So it has to do with the distortion and the scatter of light. So kind of what we mentioned with the cataract itself becoming more hard in density, it also takes on kind of more of a yellowish hue. And so those two kind of optical factors then cause when light is hitting that lens to get dispersed and lead to that glare in the vision.
So they ask, is that why they're having trouble seeing at night lately?
Most likely, but once again, another reason to have a thorough eye exam to just determine what is affecting your vision, just because sometimes cataracts are there, but then other things like severe dry eye or ocular surface changes can make the visual effects of the cataract worse. So sometimes we can optimize a dry eye and then reassess the cataract to see if it needs to be removed or not. But once again, just making a point of why it's important to really have an annual eye check and exam, especially if you've got a cataract diagnosed.
And will supplements help, for example, AREDS?
So at this time, we don't have any recommendations for supplements for cataracts. Now, wearing UV protection when you're outdoors, we didn't really talk about this, but smoking is a risk factor for cataracts forming. And just overall healthy lifestyle choices may slow the progression of a cataract. But there hasn't been anything to show that the AREDS supplements would be helpful for preventing cataracts. Now, AREDS, those are supplements that are more geared for people that have macular degeneration. There was a study that showed that patients that had kind of advanced macular degeneration in one eye, taking the AREDS supplements could prevent progression in the other eye. So that definitely is something indicated for macular degeneration. Now, I don't see any problem, even if you don't have macular degeneration, to take an AREDS as long as your primary care doctor is aware. But once again, couldn't tell you that it would prevent a cataract from progressing. But lots of UV exposure, definitely, and things like smoking.
We have another question about the IOL power.
So everybody's eye is a different shape and different size. And so based on the curvature, the diameter, the overall axial length, the lens power is different per patient. So that's why we care about our pre-op measurements. And then one other thing we just didn't have time to talk about, but I'll bring it up today, is that we do have ability to recheck the lens power during the surgery to confirm after the cataract's been removed while our patient's on the table, that lens power is the correct power. So it gives us more accuracy as well. That's not covered by insurance, but definitely something that's worthwhile to consider, especially if you're going for one of the premium lenses. But basically, the IOL power has to do with the focal point of where the images are going to be focused on. So it's going to be different for every patient.
Is it ever possible to redo cataract surgery if you're not happy with the results? Unfortunately for this patient, theirs was done using monovision and their brain cannot adjust to that.
Yeah, so ideally we would like to do the surgery once, just because one surgery is always better than having to do multiple surgeries. But this does not mean we cannot do a lens exchange. It's always an option to do lens exchange. And this is something that at the Gavin Herbert Eye Institute, we do a lot of. We support the community just because it is a little bit more of an involved surgery that takes some extra skill. So me and my partners that are cornea specialists, this is actually a technique and something that we specialize in. But there could be other potential options to avoid having to do a surgery. One would be potentially a LASIK or PRK touch-up that we could, if it would be safe for the eye, or potentially glasses or contacts. But yes, the answer is we can exchange the lens down the line.
Is the laser procedure as safe or safer than removing cataract by ultrasound method?
So it is not covered by insurance because there has not been any large-scale studies to show that there are definite prevention of complications with the laser. And so that's kind of why it is still an out-of-pocket option for patients. However, as you can see with the laser, you're definitely getting more precision, and also healing time is quicker after the laser. So my feeling is that if the laser is in your budget and it's something you can consider, I would recommend it. If not, we've been doing cataract surgery with ultrasound for decades and had very good results. One area that I think would strongly consider a laser is if you're going for one of the premium lens options. With those, we want to do everything possible to give you the best visual ability to see contrast. And with those, potentially having that perfectly circular opening or being able to treat all the astigmatism would be indicated. So definitely in any of those premium lens options, I would strongly recommend it. But on the other hand, we don't see a drastically huge difference in complications with the laser versus not. I think really at this point, it's more potentially better visual outcomes.
Great. The next question, forgive me if I get the technical term incorrect. Someone asked, with patients with a cornea cell count around 1,500 cells per square millimeter, I believe was the question, is it safe to have cataract surgery? If so, will he benefit more from laser capsulotomy than traditional ultrasound capsulotomy?
Yeah, so there are conditions of the cornea, and I'll just admit it to you, I'm a big cornea nerd. This is my passion. I not only do cataract surgery, but I'm involved with a lot of corneal transplants and corneal surgeries as well. So something like Fuchs corneal dystrophy can affect the pump cells of the cornea. And so the question here is talking about a lower than average cell count of a cornea and whether that can handle cataract surgery. So for the most part, 1,500 cells should be able to handle cataract surgery. But in cases where it's borderline, we can consider doing a corneal procedure at the same time to help supplement those pump cells, such as a DMEC or DSEC partial corneal transplant. But really in this kind of scenario, it'd be really important to base it on the surgeon's physical exam of the cornea to see if the overall pump cells are healthy and can handle the surgery, if not considering a combined surgery. There are numerous studies that are out there. It's kind of all over the place. Some studies found that doing the laser in someone who has a corneal condition like Fuchs may be helpful and beneficial. Others have found very similar outcomes. I think if the laser was an option for someone who already has a low level of pump cell function, would be a recommendation. On the other hand, once again, considering a combined approach if there's any concern that the cornea is not going to be able to recover from the surgery. But just being clear, this is a specific condition that affects the cornea and not everybody has the same pathology.
How many times can you do laser for posterior capsular opacification?
I would say the vast majority, this is a one and done procedure. But I have seen some cases where the opacification potentially has come back. And so we can continue to do this procedure. There's no set number. Other times, sometimes that membrane that forms is pretty dense, so we can split it up in different sessions. But it's more the energy that's kind of dispersed that day. You can have multiple laser procedures if they're needed.
YAG laser capsulotomy post-cataract surgery is done once for all, or is there a chance that it could be done more than once?
I think kind of goes similar to the previous question. It could be done multiple times, but for the most part, the vast majority, it's a one-time needed. And for the most part, everybody's going to develop this at some point after the cataract surgery. It just kind of depends on healing and overall, genetics, I'd say, of when this happens. Like I said in the presentation, sometimes it doesn't happen for 10 to 20 years after cataract surgery. The modern lenses that are have been designed now, the rates of these are actually much less with the newer lenses because they kind of prevent that from happening. But once again, it's not a bad thing just because when you have the laser, the vision goes right back to what it was.
How satisfied are patients with the monofocal lenses compared to LAL or LAL plus?
So this patient knows, or this attendant knows a lot. LAL is a light adjustable. So there is a LAL a regular lens, and then there's an LAL plus. And so that lens has more of an extended depth of focus. And if you guys remember from the slides, this lens we can adjust after. I have to say that all my patients that have gone with this lens are very happy. And this is the same lens that I helped my father choose as well, and he's very happy after the surgery. I think the differences between the LAL and the LAL plus, the LAL is a great lens in general, but also great lens option for someone who's had any sort of previous refractive surgery like LASIK or PRK, just because it allows us to kind of adjust for some of the irregularities of the cornea after laser procedures. The LAL plus, at this time, kind of recommending it more for patients who haven't had any previous LASIK or RK or PRK, but we're seeing great results with both of these lenses. I really think the only downside of these lenses is that there's an out-of-pocket cost. Otherwise, great outcomes. And for me, I love giving or handing over to my patients and letting them decide what it is, the focal point that they want.
Next question is, how are light adjustable lenses adjusted? Start with distance and adjust to near. Can it be reversed back to distance?
So the lens itself has an active shield. And so when we're doing the adjustments, there's a programmed UV light that opens up that active shield. And then with a different wavelength, we're actually able to flatten and steepen the lens. So for the most part, we usually start aiming more distance, and with the treatments kind of set things for more and more nearsighted if that's what the patient wants, but we can go back. Yeah, I think that hit the question.
How successful are IC8 lenses? What are the pros and cons? It seems like these would be the best option.
So IC8 is a great option. I really think it's a great option for someone who's tolerated monovision before, because with this, you're getting that near focal point, but still preserving the distance vision. So I think this would be a great lens for someone who did really well with monovision and they want to bring that back now, and they don't want to give up the depth perception that you might lose having the two eyes being so far from each other. I do think, for example, even with the LAL, the light adjustable, with that lens, you're getting some depth. So even doing monovision with that lens is helpful. But I think the IC8 monovision patients, and also someone who has kind of an irregular cornea, whether they had previous RK back in the 1980s, maybe if they're like mild keratoconus, this lens would be a great option. Obviously, none of the premium lens options would be a consideration for someone with keratoconus or an irregular cornea, whereas the IC8 kind of opens up that door.
How common is it to leave a piece of cataract in after surgery? My friend just had cataract surgery and her one eye is still dilated and may require another surgery.
Yeah, so this can happen. I would say, it's not common, but maybe potentially about 0.5% risk for this. And so this is where a microscopic piece of the cataract during the surgery, it lodges itself behind the pupil, doesn't come, and then a few days after the surgery, it can make its way to the front of the eye, and then we can see it. If it's a small piece, for the most part, this is something we manage medically, where it'll dissolve on its own. If it's a larger piece or causing any problems, that's where we would consider probably taking the patient back to the operating room to remove that remaining fragment. This as well is not common, but I think I said 0.5%. It probably happens at less than that, maybe 1 in every 2,000 cases, I'd say. But it is something that we can remove that cataract, and in most cases, the vision will still go to its potential.
Are there any drawbacks that multifocal IOL has compared to standard IOL?
I think the main thing here is that anytime you're gaining extra focal points, you're losing potential contrast in your vision. Or what I mean by that is that, like, kind of that halo around lights at night. With the multifocal, this lens is giving you the most focal points out of any lens that's available. So I think there's a kind of a ratio there to consider, of having really good distance with a monofocal, but then needing glasses for computer and up close, versus a multifocal having those 3 strong focal points, but potential for a little bit reduction in contrast or quality of vision. Now, with an eye that doesn't have any other issues, not a big deal. But for example, 10, 20 years after down the line, if someone has changes to their eye, like diabetic retinopathy or worsening glaucoma, then you may have 2 potential issues that could be affecting your quality of vision, and that would be different than just coming from the multifocal. So I do think this goes down to the overall background of the patient's health and their eye, also with what their expectations are. If they really want to be independent from glasses for most of their day-to-day, then the multifocal is a great option.
Dr. Behshad, are you able to speak to the cost of laser and premium lenses?
For the most part, laser cataract surgery adds about $2,000 extra per eye. And then the premium lenses, they're priced anywhere, including the laser, anywhere from $3,900 to the light adjustable, that's about $5,900. So there is extra cost, and that's per eye. But really, this is an investment, and this is an opportunity that our patients can actually decide the type of vision and what they're looking for from that point on after their cataract surgery. And it's just amazing how great our patients are doing, and being able to resume their day to day. Even with me seeing my own father, just being a passenger in the car and seeing how much safer I feel when he's driving. That is just it does demonstrate of why these investments they can definitely be worth it.
Is it common to have collagen floaters after cataract surgery?
So for the most part, floaters are from the back of the eye, so separate from the cataract surgery. That's the jelly that we had talked about in that initial diagram. So as the jelly matures, it becomes more liquidy, and we can get floaters that move around. Now, what can happen after cataract surgery early on, because the cataract was impacting the light getting into the eye, when we remove that cataract and we put a clear lens, more light gets in the eye, and early on patients may notice their floaters more because there's more of a shadow, but over time the brain kind of adapts to that, and then it kind of stabilizes. But floaters are in a different area of the eye, and for the most part we want to avoid the vitreous when we are performing cataract surgery.
Well, we had so many great questions tonight. I think this may be the last one. They want to know if dry eye is a common side effect after the surgery, and if so, how to deal with it.
Yeah, so for the most part, dry eye is a very common condition, and I'd say in the vast majority of my patients, it's there before the surgery. And then after the surgery, our patients have to use all these different post-op drops that kind of feel like you're lubricating your eye because you're using 3 different medications 3 to 4 times a day. But those drops actually can make your dryness worse. And so it's really important not only to consider it after the surgery, but even beforehand to optimize dry eye and ensure that it's improved. And then even after the cataract surgery, using artificial tears on top of the post-op drops to kind of prevent any sort of dryness getting worse or affecting the quality of vision. So once again, this is why you really want to go to an area or a location for your cataract surgery that is also a dry eye center, just because places like the Gavin Herbert Eye Institute, we're very sensitive to this, and we have all the latest and greatest options for treatment of dry eye. And I think this is a great segue to consider signing up for the webinar that we have on dry eye as well, just because we talk about a lot of the options and when it comes to cataract surgery or just in general with dry eye treatment.
Thank you, Dr. Behshad. I think that about covers it. And thank you all for joining us. And thank you, Dr. Behshad.
Thank you, everybody. Have a great night.